by Colleen Cicchetti. Dr. Cicchetti is the Executive Director of the Center for Childhood Resilience, clinical psychologist at Ann and Robert H. Lurie Children's Hospital of Chicago, and an associate professor at Northwestern University's Feinberg School of Medicine. You can read more about her life in the bio and in our website. We're happy to have you with us, Colleen, and she'll be talking to us about building trauma responsive schools through school community collaboration. Take it.
Thank you so much. And this is just such a perfect setup because the work that I'm going to describe is actually a path that we have followed since Chicago Public Schools first got some of their Safe School Healthy Student grants. So I think it's a nice continuity here to kind of build on some of what Ron told us, and hopefully by the end demonstrate ways that we as a city and state in Illinois have been able to build on so much of the models that he started to create a trauma responsive model for our entire state that builds on many of the same constructs that came from the Safe School Healthy Student grants and building out the multi-tiered system of support. So let's jump right in and let me just tell you a little bit about who I am. Next slide, please. So as Tioni said, I am a psychologist in Chicago. It's actually Northwestern University. And I started this type of work in 2004. So again, think about the timing of the Safe School Healthy Student grants were launched in 1999. My first interaction with them were in 2008, so a couple of years after that. But before that work, I actually gotten some funding to do more of a traditional research study that led to the work that I'm doing now. So our Center for Childhood Resilience is really looking at this idea of what is the role of a public health approach? How can mental health providers and academic children's hospitals intersect with the communities and schools where kids live, learn, and play to try to prevent the types of challenges that we're having in addressing mental health services. So I do that with a team of about 25 people. I had a picture, but that crashed our PowerPoint. So let's go to the next slide and I can tell you a little bit. So really, this is our goal. Our goal is we are the public health arm of our Department of Psychiatry at our Children's Hospital here in Chicago. And our goal is to think about how do we make sure that kids aren't on our wait list, trying to get into our emergency room, trying to get into our inpatient unit, but instead have access to mental health services provided by their trusted adults in their lives and communities so that we can only be seeing the most challenging kids in the hospital. Unfortunately, that's not how our systems are working right now in most of our country. So the next slide just kind of talks a little bit about that intermediary role. So again, I am trained as a clinical psychologist, like some of my colleagues here on this scientific board. My work was originally, I was trained to see kids in my office, many of whom had experienced violence and trauma, and to do individual or family therapy with them. But over time, what we've really come to learn is that there are opportunities for shared learning if we look at the link between the communities and the academic science and trying to really think in many of the ways that Ron just mentioned, how do we bridge that? How do we take what we know has evidence that works and think about the feasibility of delivering that in communities with community partners? And that's really the way that our team is sitting in that space, trying to both honor the expertise and knowledge of communities and schools and students and families, and also leverage what we know works if kids get to our hospital. Next slide, please. So again, based on everything that you've heard, we know that there is a huge mental health crisis in our country. We know that about 50% of kids who need mental health services ever get them. Of those that do, and this is why this conversation today is so critical, 58% of them receive them only in their schools. There, in our area, we know that it could be 75% to 80% of kids will never see a mental health provider other than the ones in their schools. So the work that we're doing in schools is absolutely essential, both to identify kids at the lower end of need and link them to higher end services, but also just to deliver the most important services because this is where kids are getting them. Next slide. Everything that we were just listening to Ron say that we've known since those original horror stories of school violence in the early or the late 90s has continued. Most recently in 2021, all of these major organizations, the Academy of Pediatrics, Child and Adolescent Psychiatry, Children's Hospital, have said we have a national state of emergency. Our children's mental health system is broken, and we are not meeting the needs of the kids that need services. And so we need to be thinking creatively. And so all of the work that we're talking about today is really thinking about how do we do that? How do we expand access equitably and with good care, and know that if a kid is getting an intervention, the right kid is getting the right intervention at the right time, as close to their home as possible. And that's really the goal of this work. Next slide. So this is just another example, just to remind you of how much worse things have gotten. This was a sample of 7,000 high schoolers that was taken in 2021. And what we see in this sample, that was a national sample, is that when asked whether they'd experienced persistent sadness, 44% of kids said that they had been experiencing persistent sadness in the last couple of weeks. So think about what that means. Half of the kids in our community during the pandemic were experiencing that. What's interesting, though, to notice is that in addition to the persistent sadness, we also see really high rates of suicidal ideation. So as many as 20% of kids in that dark purple are saying that they experienced some moments of considering suicide. So this is not just mild mental health concerns. These are significant mental health concerns. But what's really important about today's conversation is that when they sampled these students and looked at those students who did not feel connected to school versus those who did, the purple is those kids who experienced school connectedness. So what we see is that the overall levels of sadness, persistent sadness, and suicidal ideation were decreased in students who reported that they felt connected to their schools. And so that's what this work that we're talking about is all about. How do we create connected relationships to support and sustain our kids through their teachers, through their out-of-school providers, through their parents? And that's really the focus. So it's hopefulness that we can do this. What we know is that exposure to trauma is very, very high. One study that was before the pandemic, back in 2013, when they interviewed and surveyed 16-year-olds, 60% said they had experienced some type of trauma. The other thing that we know is that trauma doesn't impact just your emotional state, it impacts your functioning in places like schools. We think of this slide as our administrator slide, because the fact is, if we don't deal with trauma, the very same things that schools are being evaluated on, like their referrals and suspensions, like their graduation rates, like their ability to perform an academic test, all of those are being impacted by trauma. So this is something that we have to deal with. It's not just because it's convenient to do it in schools, but it's because it's critical. Next slide. So I just want to do quickly a definition of trauma, because trauma is one of those words that 20 years ago we were fighting for people to understand what it is, and now we're at a point where we need to make sure that people aren't using it inappropriately. It's being used a lot, and so I want to just share with you what SAMHSA has adopted for a definition of trauma. I'm proud to say that Illinois actually helped develop this and presented it to SAMHSA, so it was adopted. So the basic idea is that there's 3 E's. The E of an event is something has happened to this child that was incredibly scary. At the moment, they might have felt like they were going to die, or someone that they knew. But the idea is that an event has happened. It might be a one-time acute event, like a car accident or a natural disaster, or in many cases, it's more chronic stressful events like domestic violence or community violence and systemic and historical poverty. So what we've seen is that both of those things, can you go back, please? That's really critical for the event. But the other thing to remember is that it's not enough. It's not just what happened to you, it's how you experience it, how you make sense of it, how close you were to it, did you feel responsible? That's why we might have 2 kids in the same family who've experienced the same event, but we don't see the same effects, because how you cognitively make sense of it is important. So those 3 E's are really important when we talk about trauma. Next slide. We also want to be clear that we're not just talking about individual trauma. Much of the trauma work that's been discussed in our country, especially in our pediatric colleagues, is around ACEs, which are individual child and family traumas. When we talk about trauma, we want to be thinking about those experiences, but also what are the ones that we're all experiencing? So things like COVID-19 was certainly a disruptor for all of us. It created stress and disruption of our routines. But for some of our young people, it also was toxic stress. That was food and housing insecurity. And then for some, there was actually trauma and traumatic loss, where domestic violence or loss of a loved one without the normal rituals. So when we think about collective trauma, it's what happens outside of your own nuclear family that can cause trauma as well. And the next slide talks about, we also need to be thinking about, historical trauma. So these are the things that happen from generation to generation. And we increasingly understand that there's a biological change that happens when your body has experienced trauma that gets passed along. And so these things can play out in multi-generational trauma interactions, but also physiology. And community trauma is something much broader than just violence. It can also be the lack of opportunity, et cetera. So the next slide really points to how we like to think about this. It's really looking at trauma in a deeper way. I'm sorry, can you go to the next slide? There we go. This slide is looking at the state of Illinois. And the reason this is really important for you all, that I know many of you are in Florida and many of you are in different parts of the country watching this, most people were considered concerned about trauma in urban areas. But when you look at this map, Chicago's up in the very top right corner in a medium green. If you start to look at the intersection of poverty, violence, and trauma, we actually see that rates are even higher in some of our rural and suburban communities. So I think one of the things that's happened in the last 10 years is we're no longer saying that this is a problem for those people or in those cities. What we're now starting to see with the opioid epidemic and then the pandemic, that we have trauma occurring in every community, in every city that we all come from. And we need to be thinking about this from a universal perspective. Next slide. So this is really how we think about this. The ACEs model you might be familiar with. If you're not, it's worth looking up. That really focuses on those individual adverse childhood experiences. But the way that our team and the work that we do in Illinois is focused is really thinking about this expanded model that doesn't just talk about the top 5 parts that are individual adverse experiences, but really does look at the overall conditions, the historical trauma, and thinks about trauma as having that epigenetic and biological impact. So we need to be thinking about how do we screen for, recognize, and understand the impact on our students for all of these things. So that's sort of where we start with trauma. On the next slide, we talk about what this looks like. So the original ACEs was really those leaves on the trees, the things that happen in your family. But what we really want to be acknowledging in this work is that it's not just what happens in those leaves, but it's what's happening not just only in your roots, but in the ground soil that you were grown in. All of these things can impact your biology and set you up to have trauma responses that can manifest in schools. And the next slide says that while that's the case, I couldn't have done this work for 20 years if there wasn't this thing called resilience. Because if we thought that trauma just led to horrible outcomes for everyone, that would be a different model. The model that we know is that trauma can have negative impact, but it also intersects with all of your protective factors. So what we know is that each of us has internal factors and assets that we were born with that can help us to manage stress and life problems. But more importantly, we have positive factors in our environment that comes from our family, our caregivers, our communities, our schools. And those two things interact, the assets and resources, to really help us to build the capacity to respond to stress. But one of the things I want to be really clear about is that resilience is not static. You're not born with a set of resilience and that's what you've got. It's like a muscle. We have to grow it. So it's really important that when we think about resilience, it doesn't just sit in an individual. It's not something that you either have or don't have, but it's something you have to grow as you move on. And that's what the focus of all this work is about. So let's jump ahead then. So what does school trauma-informed principles and practices even mean? What does it mean to think about all the things that I just talked about? The next slide goes into the starting point that we always start when we talk with any group of adults that works with young people, which is the idea of the invisible backpack, which is that kids walk into your space and you have no idea what's in that backpack. They walk in with all those school supplies and those giant backpacks, but buried in there is a notion about Who am I? Do I belong here? Can I be successful here? Do the adults in this space like me? Do they think I belong here? Are they going to protect me and help me be successful, or are they going to make me feel that I don't belong? And so what we really want to be thinking about is, unknowingly, are we somehow creating a much more depressive, hopeless view, or are we, whenever a kid shows up in any of our spaces, making them feel safe, capable, and lovable? And if we start with that's what every child deserves when they walk into a school building, that's a really important place to start. The next slide says, then, how do you do that? So again, you've heard the talk of universal spaces. It's not just individual treatment for kids. It's creating a space or a building where all of these things fit together. Our team calls this our hamburger slide, and it takes those three things that are in the middle. Those come from SAMHSA. What are trauma-informed spaces? Trauma-informed spaces feel safe physically and emotionally. They're based on building relationships and connectedness. It's the idea that you don't show up and have a different teacher every single day and expect to feel safe. You have to have that stable, predictable relationship. Same with when you go to the doctors. You don't want to see a different provider every time you come. That doesn't feel good. Our pediatrician colleagues are really working on that. Then the third thing falls under that teaching and supporting emotional regulation. And that looks a lot like social emotional learning, which we'll talk about later, probably in the discussion. But the idea is that in a trauma-informed space, you are helping the folks who show up and are facing challenges to manage that situation and giving them opportunities to learn and being reinforced for doing that. What we know is that those SAMHSA opportunities are critical, but we can't do all of that unless we use the buttons. So we need to start with self-care, or increasingly we're thinking about it as collective care. How are the adults and the people who work in those spaces taking care of themselves and each other so that they can continue to provide the spaces that are in the middle? And are we doing it from a lens that really does think about the folks that we serve, whether that's students or adults, bringing their own culture, their own views of the world? And are we thinking about how do we do this in an equitable and safe way? So this is the goal of school-based trauma-informed care, creating this kind of a model that supports both the children and the staff that work in every school. Next slide. So what that means is, can you click it again and again? What it means is we have to think about, what does this actually look like? We know that there's a vision, that students feel safe, that there's support for everyone, that kids feel connected, that people are, working in shared responsibility. But we know that in order to make that happen, you have to have a very specific plan. And that plan includes building that infrastructure and culture, staff training, thinking about what does this look like for kids in their classroom? What does it look like for kids who need to be pulled out? And do we have to think about connecting with other behavioral health specialists, because we may not have the resources in our own building? So this model came from our colleagues at Harvard Law School, and really is important, I think, because in order to do this work, you have to decide how you're going to make this kind of happen. And the only way to do it is with sustained attention and detail. So the next slide shows us how we've tried to do that in Chicago Public Schools. As I mentioned before, Chicago Public Schools did get some of the early Safe School Healthy Student grants. At the time, we were really thinking about building mental health supports. In the last 10 or 15 years now, since about 2005, what we've done is really try to integrate within the multi-tiered system of support, what does trauma-informed care really look like? So that means building that awareness. It means creating those structures and having tier 2 and 3 interventions that are actually able to be delivered in schools that focus on trauma. Recognizing that we absolutely needed community partnerships. Our schools were not staffed to have enough mental health providers in them. We wanted to do exactly what Ron mentioned, which is make sure that we're using evidence-based interventions. If we're pulling kids out of class time, we better make sure that what we're giving them is actually going to benefit them. And we want to make sure that we're doing that data collection. So we're tracking, does this intervention actually help? And so these are the core components that we've done within Chicago Public Schools that have then become the basis of what I'm going to describe happening across the state. So the next slide is, again, thinking about building in trauma-specific interventions. So these are just 3 national best practices that if you're not familiar with, I would recommend strongly that you getting trained in. Cognitive behavioral intervention for trauma in schools and bounce back were both developed by the same group through a National Child Traumatic Stress Network grant originally out at UCLA. It goes from K to 12. And then Sparks is more recently developed. It came out of the juvenile justice world, and it is now being delivered in schools. That was developed by our colleagues, Mandy Habib, and blanking on her colleague. Sorry, it's in there, Victor Labruna. So Sparks is developed for folks with chronic stress and trauma, and we have found that very useful because it's based on some DBT principles, and it's really acknowledging the fact that many students have not just had a one-time trauma event, but are experiencing chronic trauma. So those are 3 interventions that I'd be happy to provide more information about if people are interested. All of them are NCTSN endorsed. So the next problem that we have is we knew we were doing this work. We felt really good about the data we were collecting and the evidence that we were showing in Chicago. But what we learned is that there really is a challenge. And that is that more and more people are talking about trauma-informed schools. More and more people are saying this is critical and we need to put resources to it, including in state and federal governments. But the fact is there actually isn't much data on any of it. And so again, this idea of bringing that academic lens and saying, how do we start to make sure that we have common language, that we're all talking about the same thing, and that we know what the right interventions are and do they help our students? So that was important to us. So on the next slide, you can see why. One of the things that we know is that on that next slide, it talks about implementation science is really critical. So logic models like Ron just talked about, and being able to really think about what am I hoping to impact? What are the short-term and long-term goals that I'm focused on? So it's really important that we do that and we look at what is it going to take to change practices? Because on the next slide, it really highlights some of the things that we know. It doesn't change your practice in your classroom to just sit through the 6-hour webinar today. What's going to take is not just hearing about these things, but actually practicing them and getting feedback and getting supported implementation and saying, I tried this, it didn't work. Meeting with peers, having near peers really model and teach you this. So what we've tried to do throughout all of our work is say that we don't ever want to just train and go away. We train and we sustain and we build the capacity for folks to do this. And that has been absolutely critical. And one of our challenges for how to sustain this is how do you build models that allow people to do that? Next slide. So the question became is really, can we come up with a model for Illinois? Can we make sure that if one school says they're trauma-informed and another school says they're trauma-informed and you say you were trained in trauma, that we actually even know what we're talking about? How do we make sure that one school that sent a couple teachers to a webinar for an hour and another school that spent 5 years, that we can differentiate it? So while we were thinking about this, some good things were happening. There were some new tools that were being developed. There was an effort to think about how do we really move these forward and create opportunities to fund and support folks doing this work. So that's really what the path that we've been on for the last 20 years is all about. So the next slide shows you what this tool was. So one of the things that emerged at around this time was that our colleagues at UCLA brought together national experts and said, what are you all talking about when you talk about trauma? And they went through a Delphi process where we all came in, shared what we were talking about, what we thought the core elements were, and they did a process to identify all of these content. And these were the 8 domains that came up. So it goes from whole school things like safety and prevention planning, and does the whole school have good classroom strategies and knowledge about trauma, all the way up until, do you have trauma-informed interventions? Are you supporting your teachers to do this work and keep showing up? And are you engaging your families? So this tool is now available on the SHAPE system and accessible by any school in the entire country. So the timing of this has been really great, because when this came out, we now had an opportunity to start leveraging a tool that we could all use. So the next slide gives you an idea of what you get if you do that. Anyone can go on and do this. What you do is you answer questions and score yourself on a scale of 1 to 4 on a number of different items. And then those items collate into a scorecard that looks like this. These are some examples. What you can see here, everything is scored as red, yellow, green. So if you're demonstrating this, mastering it, you're green. If you're starting to demonstrate it and showing some evidence, you're yellow. And if you're struggling with it, you're red. And what you can see on this is that we didn't have any green in our initial schools that we did this in Chicago. And that the areas that were the most difficult were staff self-care and doing something to make sure everyone in the building was aware of trauma. And that is a pattern that we have seen again and again and again. So we started this in Chicago, and then we've started replicating this. So the next slide talks about this path. So I'm going to go through this really quickly, but if you want more information about any piece of this, I'm more than happy to talk to you about it. But what I want you to see is that this has been a 6-year path for us to go from working with one district to really thinking about, does the work that we're doing in that district, built on things like Safe School, Healthy Students, does that work for the whole state? And so I'm going to walk you through a couple of pieces of the puzzle along the way that just helps you get to where we are today, which is at the REACH project. So the next slide talks about our first pilot. So this was a pilot funded through the Justice Authority with funds from the Victims of Crime Act. And we had 2 sites in the state that did this. Again, just to give you the idea, this is that original data that I mentioned in Chicago. The baseline data was exactly what I showed you before, but with more schools, which was that whole school trauma and staff self-care were the lowest when we started this at the beginning. The next slide shows you what happened after we invested in doing this work and creating action plans and moving forward. What we saw in Chicago is that all of these scores went up over the course of the 2 years for schools that stuck with us. The biggest jump was in the staff self-care. The smallest jump was in the targeted trauma-informed programming. So that's where we're thinking about putting in interventions. Part of that in Chicago is that we had been very focused on providing those interventions in CPS from the Safe Schools Healthy Student Grant. So we already had some of that. But if you look at the next slide, this is Southern Illinois, where we were also doing a pilot with the same funding. Again, what we saw in that space was growth on all of these areas. The staff self-care was one that went up a lot, but the trauma-informed programming jumped super high because we had not been able to provide training in Southern Illinois for those same interventions because they're such small districts until we got this influx of funding. So again, you see very similar patterns. We're starting to feel like this measure really works. So the next slide talks about a pilot that we did funded by philanthropy. So before we started expanding this, we wanted to make sure it worked in urban, suburban, and rural schools. We were also at the time, back in 19, when we proposed this project, wondering about doing this online versus in person. Our team has 20 people. We were going on site and teaching this. We realized to go statewide, we had to create a network and we had to look at, could we do this work virtually? So the timing of that worked quite in our advantage because as you see, SY20, when we started this, was right at the beginning of the pandemic. The good news about this is when we did this work in all of these settings, we saw that we had the same types of outcomes as we've seen in the previous study. So we felt ready to say that this really is a tool that's useful and these learning practices are important. Next slide. So we were ready for this, and then the pandemic hit. So the pandemic hit and a lot of things changed, as we all know. Next slide. In Illinois, we were looking at some pretty challenging things. Our State Board of Education had been monitoring the children's mental health crisis. Our scores kept dropping. We had gone from not so great to even lower. We found that tons of kids were having depressive episodes. 95% of Illinois counties did not have adequate mental health needs. 81 out of 102, think about that. 80% of our state did not have even one child and adolescent psychiatrist. Our ratios for all of our school-based folks were completely not meeting the expectations for the national recommendations. And the thing that started happening that was really scary for our State Board of Ed is that 15 to 30% of teachers, when polled during the pandemic, said they were thinking about a career change. So starting as early as 2020, ISB, our State Board of Ed, said we have got to prioritize SEL and mental health or we are going to lose our teachers and continue to have a crisis. So they were coming to this at the same time as we were building this whole model. So the next slide points to this new REACH project. They reached out to us and said, we need help. We need help for all of our educators across the state. They're telling us that they're struggling. We want to get something to them immediately. And we also want to really build out a model to bring the deeper work that you've been doing through some of your pilots to the whole state. So what we decided is that we wanted to do this in every school in the entire state, K-12. We wanted every school to feel like they were getting the support they needed, to have the adults that could help them, the students to do well, to have the caregivers feel engaged, but also to create a system where not Lurie children sitting in Chicago was doing this, but that the whole state was doing it. We also decided to prioritize our efforts first in those schools that had the highest rates of trauma. So we went into the schools where we had the biggest challenges, the schools that were performing the worst in our state. That's where we started our first pilot statewide. So the next slide goes into that pilot and then moves into this is a very simplified version of our logic model. Ours looked a lot like the one Ron sent you, but I decided not to put that on the screen. But the idea is that this is what REACH is trying to do. We work with adults. We're creating through our team and our partners these SEL hubs. There were 6 created across the state. We trained them to be able to use the TRSIA and train their school districts and schools within their districts to use that tool and create action plans. The goal was to get to 850 schools across the state, with this goal ultimately for the kids to experience exactly what we've just been talking about, a school where safe, supportive, culturally attuned, where they're able to thrive. So that is our logic model. We can show you another example if you want to see it at another time. But the next slide talks about what does this look like for a school? So if you're a school in Southern Illinois or Central Illinois, and your regional office of education leader reaches out to you and asks you to participate, you enroll. The first thing that you do is you get involved in these asynchronous trainings. So we made webinars with the core constructs of trauma-informed care. What is the intersection between trauma, race, and equity? How do we promote teacher self-care? What does teacher social-emotional learning look like? We put together a bunch of things very quickly and got them out to people. So those asynchronous trainings are available to any educator in the state of Illinois or beyond. We also then said, if your school is going to be involved, you need to make sure your schools have seen it. So you need to bring those tapes, those webinars, and get your school to participate. Then we're also going to give you materials to do live facilitated sessions. Then you're going to actually create a team. You're going to have 5 or 6 people on a team, including a teacher, a social worker, an administrator, a community parent representative, and you're going to think about, what does my team look like? So you're going to complete that TRSIA, but in a group process, and create an action plan. From that, you're going to decide, do I want to engage in the REACH provided communities of practice and additional learning resources, or am I going to keep doing what I've done with my ROE or locally, or maybe with my teacher union to build my trauma-informed practices? And then yearly, I'm going to redo that TRSIA and track to see if I'm getting better. So that's what a school experience is. Next slide. So what we're trying to do here is really get this out to as many people as possible. So like I said, the way to build from, our original pilot was 50 schools, and we're now up to almost 500 schools. The idea is that we have these trainer of trainer. We teach these ROE hubs to do this assessment. Then we put together in the first year a set of communities of practice that adults in different schools could log into for 6 to 8 weeks and really build a specific skill set. We now have over 20 providers of communities of practice across the state that folks can opt into. So we've expanded the people who can do that. And we brought in AIR, also mentioned before, to do the evaluation and monitoring of all of this. And the idea is that all of that is available to those schools that are involved and are specifically engaged. But we also have, beyond that, we have the Universal Learning and Research Hub. So like I said, we've had thousands of people joining that to try to get information, so that if you're sitting in a school where your administrators are not ready to do this work yet, but you feel like you need support, you can get that. The other thing that we're launching is an opportunity to create what we first said was going to be a Resilient Schools designation, but we're now calling it a certification, where every school in the state, we could give them a score on if they're doing this work. I'll talk to you some more about what that's going to look like. But the idea is that this needs to be universally applied across our state. Next slide. So in order to do this, we have to have a lot of partners. This project was funded through the ESSER 2 and 3 grants. So the emergency response grants that came through the federal government have been providing us the funding. We're going into year 3 this fall. So these are all of our partners across the state. Next slide. This is what we've reached so far. So you can see that this is statewide, which was really our goal, with clusters in Southern Illinois and up by Chicago, because that's where we've been doing this the longest, but we've been able to, through those ROEs, get this across the whole state. Next slide. And so this gives you where we are right now. We're at 473 as of 2 days ago. It's growing every day. And what we're finding is that the people who participated believe that it really is helpful. What we've heard specifically, and I have videos of them as well, is from principals that this gave them a way to really think about what they're doing in their schools to support their students and to measure it in a way that makes sense to them and to start tracking. And they felt like being able to use this tool and work with the team, they were able to honestly assess where they are today and then make plans and allocate resources to move it forward. Throughout this process, we've played with many, many details that I'd be more than happy to talk about with people around how to do this, how to incentivize, can we use funding to pay for out of school time for training? We gave every school some money to put in place some piece that they wanted to do. So we've really been looking at blended funding. What we're finding is that the schools really do believe this is helpful. We're also finding that the communities of practice where they come together and learn from each other are absolutely essential because they're able to really support each other in trying to make these changes happen. You'll see we've got over 9,000 people that are on the resource hub already, and we're finding huge progress in terms of their topic knowledge, even doing some of the most basic trainings. So we're feeling good about this. Like I said, we're about to go into year 3. Our goal is to get to the 850 schools with the ESSER funds, and then we're looking at sustainability funding that I'll talk about. Next slide. So just back to where we began. And the reason I wanted to pull this up again is just that reminder that this has been a long process, starting with just a few schools and districts and moving up to where we are today. So if you're thinking about doing this in your state or in your district, just realizing how long it takes to move towards where everyone is in sync and believes this is a priority. Next slide. So through this, as I mentioned, we had the REACH project, which is really developing a model to help schools do this. But we also knew that people were doing this work before. Our teacher union in particular was really driving some work driven by teachers to do this. And they wanted to make sure that if they wanted to continue doing what they were doing, that they were still capturing and still being able to access resources by doing that. So the resilient school designation, we very quickly heard from educators, don't like that word. Let's go to certification. Designation to many of our educators felt like a bad thing because we use designation to highlight schools that were struggling. So we've adopted the term certification, and we've spent a lot of time thinking about language and how important that is. So the next slide talks about what exactly we're trying to create here. So this is where we are today. So we started this group process in December. We have 3 different steering committees that I'll show you with national experts and state representatives of every group of educators in the state of Illinois, from school psychologists, school social workers, students, superintendents, regional offices, you name it, they're in this conversation with us. And where we've landed today is on these 4 pillars, which is to say that being a resilient school builds on how are you doing with supporting mental health? Are you creating the culture responsive community and equity in your particular community defined by what you need? Do you have social emotional learning integrated into your school? And are you creating these trauma responsive and healing centered? So these have emerged through many conversations and survey data. And what we've learned is that in order to support those 4 pillars, we also need to actually do these core capabilities. So what does the planning look like? What does staff preparation look like? What are you actually doing for students in your building? How are you engaging families? And what does the learning environment look like? So this is where we stand today. I can tell you we're about to pull together our first pilot and try this with some of our schools. And the goal is to start piloting it and launching it next fall for the next school year. These are just an example of all of the experts that have been part of this. It's really important that you get lots of voices so that at the end of the day, when you put this out there, you have fewer naysayers and more people who say my voice was heard in this process. Next slide. This gives you just an idea of all of the people. Like I said, we're talking about going to the highest levels of state leaders, from the head, our superintendent of schools, our director of the Department of Public Health, state senators, state agencies, leaders from across the country, people who work in multiple spaces are all engaged, as well as young people. So in addition to these 3 groups, we have an entire subgroup that's working with getting youth voice and youth engagement across the state of Illinois through multiple opportunities and strategies. Next slide. Like I said, the initial funding for this project, the REACH statewide project, was from ESSER 2 and 3. We are still in the midst of that. But as you heard earlier in this conversation, the federal government is really putting out a lot of money. In fact, there's over $1 billion going towards children's mental health, the Bipartisan Safer Communities Act. We have been lucky in Illinois to already have received 2 SAMHSA grants and 2 Project Aware grants to a total of $13.5 million that's helping us to move this from the original REACH project into sustainability and integrating with other efforts that are happening across our state. Next slide. So how did we do this? I think it's important to just highlight that Illinois was ready for change and to think about how this might be similar or different, or what might be some critical building blocks. So Illinois has been doing this for 20 years. Back when, right around the same time as the Safe School Healthy Student Grant started in around 2003, Illinois had its first Children's Mental Health Act. That was really important. It was the first in the nation to create the SEL standards that are now national. It also created some organization within our state, bringing together people in a state-private partnership that gets folks to think about children's mental health and how to fix it. And simultaneously, there was a subgroup really wanting to look at what does trauma mean in our state? Where is it showing up, not just in schools, but in our juvenile justice and our child welfare? So we've had a lot of folks that have been very interested in this work. Senator Durbin in particular, I call him my trauma expert senator. He is just loves this. We've taken him to schools. He's met families. He's been really following this work very closely with us for the last 10 years. Next slide. So this just gives you an idea of kind of where we are. And you can see some of these points are where the federal government was. So 2001, No Child Left Behind. And then 2017, the trauma-informed care legislation was first introduced. But in the meantime, we created our own Children's Mental Health Act. We have a whole child task force that I'll talk to you about. And we've had these certification grants. So we're kind of trying to follow what the feds are doing, but also support this in our local state. So that Children's Mental Health Act was really critical because it said that mental health is not just the responsibility of the healthcare industry, but it's all of us. It highlighted that we had to have these school community collaborations, that it had to be a public health model that goes from early intervention into all the way up to care. We had to try to think about how to create linkages for families to make this navigate. So we're at 20 years since that original Mental Health Act was put in place. Couple of other things that emerged from that. The next slide talks about those original SEL standards, which should look pretty familiar because they're very similar to what we all have across the country now. And then the next slide talks about these 2 groups that were created out of it, the Children's Mental Health Partnership, which we have an annual report. We actually just got renewed legislation and have created a new document in 2022 that leads to what's coming next. The Child Trauma Coalition is literally just a coalition of folks that do work with young people across the state in all different areas, and we come together and learn with and from each other. And that group, both of those groups are housed currently at my hospital so that we can keep these going because frankly, for example, the ICTC has no funding whatsoever. So it's just a group of people that care. The next slide talks about some recent work. So recently in our state, there was a call to action from our Black Caucus saying we really need to think about what are we doing to create equitable, inclusive, safe, and supportive schools. And they asked for a group of us to come together in 6 months and come back to them and create a set of recommendations. We have done that. There's 30 specific recommendations that you can access if you want to take a look at them on our State Board of Education website. One of those, next slide, was to actually develop some definitions. So again, getting back to this idea of let's make sure we're all talking about the same thing. Whole child comes from the CDC. We really want to make sure people were recognizing what that means. And then also coming on trauma responsive definitions for what trauma responsive schools look like. As noted in the blue, we have just recently brought forward legislation in our state and House and had bipartisan support to put and adopt these definitions and to move forward 4 or 5 of the recommendations from the Whole Child Task Force, putting them into law from that work group last year. Next slide. How do we do that? You know, what has this process been like? How can you think about this? I think it's really critical if we're moving this forward that you don't work in silos. You really have to be thinking about aligning all of this work across sectors. You really have to be engaging people to think about what are the common challenges to move this forward. You need to think about things like who can be your champions that are going to really drive this and keep bringing it back and elevating it so that it's not just coming and going. The next slide talks about how do we engage with other folks. We need to make sure that this is blended funding has done this. The federal government has got money right now, but as we know, that can be fickle. The state has some money in it as well, but we also are looking at philanthropy and looking at innovative practices. Even some of our health insurance companies are looking at funding some of this work. So we really want to be thinking about all of it. We also want to make sure that we don't say this is just the work of schools. This has to be the work of the entire community. So bringing in those out-of-school providers as well. Next slide. These are some of the things that have come about that you can look at across our state. Like I mentioned, the Whole Child Task Force report. We also just had in our governor appointed someone to look at the overall state of children's behavioral health in Illinois, and we've created a blueprint to really get all of our agencies to work together. For the first time ever, we have somebody in our state, Dana Weiner is her name, reporting directly to the governor whose job it is to worry about children's mental health. It's not just education, it's not just welfare, it's not just justice. It's making all of those people come together and the governor's holding them accountable to do this work. So these are some documents that you can look at. Next slide. In this process, we have seen really good outcomes. As we talked about, Ron mentioned, we have all kinds of data we could show you about all the individual things and questions we're asking. That's not today's topic, but we have seen with this work, we have moved up until the 12th place from 36th in Illinois. So we are seeing this kind of group statewide effort leading to changes. Next slide. This is just a reminder that in order to do this work, we do want to bring along our stakeholder adults and those policymakers. Some of you are on the call right now, but also we want to start bringing the young people. So we do a lot of pipeline work through our hospital, bringing young people into the fields of health and medicine, but we also want to teach them about advocacy, and what we're finding is young people want to talk about mental health. Next slide. Just to close, I just want to tell you the work we're doing in Illinois is also being replicated across the country. So if you're interested in learning more about this, one place for you to look is the National Center for Safe Supportive Schools. This is an NCTSN grant. We are co-PIs along with the National Center for School Mental Health. We are about to start year 3, and we have integrated much of the same model with mental health supports and SEL and trauma-informed care that is accessible for districts across the state. There's many materials on the site. If you look at the next slide, you'll see what we've done is to recruit cohorts. The first cohort we had is just coming to an end in June. We're celebrating the end of their 2 years with us. And the second cohort we just brought in. So we are working with 25 states at this point, and hoping to expand as we continue. I don't see Florida on there, so hopefully we'll think about joining in the future. The other thing I wanted you to know is while this has all been K-12, much of this work is also being replicated and brought into the early childhood space. So this is just a link. This is just describing some work that we're doing with the National Office of Head Start in their Center for Health, Behavioral Health, and Safety to build this work as well. I think we're near the end. Thank you. So lots of details I'm able to provide in the future or in our discussion, but hopefully it gives you a sense of what it took for our state to move from those Safe School Healthy Student grants to doing something collectively across the state that we're building on and we'll hope will be a model for the rest of the country.